Who is starting first? Kavitha or Viveka?
I will be starting first, sir.
All right. Share the screen and then we'll start by about 8:05.
Hi, sir. I'll share the screen. So good morning, sir. Should we start?
Kavitha?
So shall we start, sir?
Okay, start.
Good morning, all. Today's clinical phytology class is regarding sulcal anatomy and migrating cortical disorder. The first half of the session we will be discussing sulcal anatomy. Um, Sulcus is a furrow-like indentation on the cerebral surface dipping into the cortex. The sulcus is lined by pia mater, which is hyperechoic, and hence the sulcus appears as an hyperechoic linear structure. Visualization of the sulcus by ultrasound is possible about 2 to 4 weeks after its anatomical appearance. Example, parieto-occipital sulcus has its anatomical appearance by 18 weeks. It will be visualized by ultrasound at 20 weeks of gestation. Ultrasound section in which a sulcus is seen depends upon the orientation of the sulcus on the cerebral hemisphere. These sections should be perpendicular to the anatomical plane of the sulcus. Here, the calcarine sulcus is oriented in the axial plane, so it will be visualized on the coronal and sagittal planes. This is the coronal plane where the calcarine sulcus is seen. This is the sagittal plane where the calcarine sulcus is seen. In axial plane, the sulcus which is which is in the far field will be seen better when compared to the near field because of the reverberation artifact. So sulcus in the coronal plane, in coronal plane, sulci on the either hemisphere will be seen clearly. So in sulcus, asymmetry is the rule. There will be asymmetry in location, time of appearance, and time of evolution of the sulcus on either side of the cerebral hemispheres. Sulci can be the sulci can be grouped according to the anatomical location on their cerebral surface. They can be grouped as median hemispherical group, convexity group, inferior group, and lateral fissure. So the sulci which are oriented in the medial surface or the parieto-occipital sulcus, calcarine sulcus, callosal sulcus, and the cingulate sulcus. So even though they are oriented, even though they are in the medial surface, the views where they are observed will be different. Parieto-occipital sulcus will be viewed best in axial view, and cingulate sulcus will be viewed best in axial and sagittal views. Calcarine sulcus and callosal sulcus viewed best in coronal views. So this is this hypoechoic band-shaped structure is the corpus callosum. This corpus callosum is lined by a linear hyperechoic structure, the callosal sulcus. So behind the callosal sulcus is the cingulate gyrus. This cingulate gyrus is lined by the cingulate sulcus. So here is the parieto-occipital sulcus, which is present between the parietal and occipital lobes. Here is the calcarine sulcus and is the cuneus sulcus.
Cuneus is the gyrus, the
Yes,
part between the pivot and the calcarine.
yes. Convexity group. So central, precentral, postcentral sulcus, the superior temporal and superior frontal sulcus comes under the convexity groups. So here is the precentral, so central, precentral and postcentral sulcus, which are oriented in the cerebral hemispheres. Convexity
Central, the small p is the precentral, capital P is the postcentral.
This is the precentral.
Postcentral is towards the occipital side.
Yes, sir. Central, precentral, and postcentral, they are located on the convexity side of the cerebral hemisphere. And this is the superior temporal sulcus. This is the lateral sulcus and the inferior temporal sulcus. So this is the coronal plane showing the superior frontal sulcus.
So go back. So you also need to know in which plane you'll be able to best demonstrate all these sulci.
Yes, sir.
For the convexity sulci, you need to take an axial view, that is cephala to the transventricular plane, which is also the view that would demonstrate the Pareto-occipital sulci best. If you see the image that you have shown for the central, precentral, postcentral, no?
Yes, sir.
You can also see the Pareto-occipital sulcus in the same, correct? Yeah. So this plane is a bit cephalad, cranial to the transventricular plane. And you need to slightly elevate the probe so that you can get the view through the suture.
Yes, sir.
Mm.
The inferior group
Go back.
consists.
Go back. For the temporal, which is the hardest to obtain of all, you need to insinuate where possible through the sagittal suture anterior fontanelle, and the coronal plane is the best plane to demonstrate the temporal lobe sulci. Okay, there are three sulcus. The hippocampal, which is on the medial aspect of the temporal, and the inferior and superior temporal, which are on the lateral aspect. Typically, the lateral sulcus, we wouldn't consider it belonging only to the temporal, but it will also be coming into view in this view. Again, for frontal sulcus, coronal section.
The inferior group consists of hippocampal sulcus and the olfactory sulcus. So, hippocampal sulcus will be seen as a bright light in the temporal region. Olfactory sulcus will be seen on the medial aspect of the olfactory lobes. So, then last comes the lateral fissure. Development of cortical development. Initially, the cortex will be completely smooth. The major fissure starts appearing by 18 to 20 weeks. By 18 to 20 weeks, the callosal sulcus starts appearing. The period between 22 to 26 weeks is characterized by a gradual appearance of the calcarine fissure and the cingulate sulcus, followed shortly by the central sulcus. Between 28 to 30 weeks, most of the sulcus will be formed. Visualization of the sulcus by ultrasound will be 2 to 4 weeks after its anatomical appearance. Evolution of the sulci. Initially, the cortex will be smooth. Later, as the sulcus starts to form, it begins as a subtle indentation on the cerebral cortex along its course. As the gestational age advances, the indentation deepens to form a broad V-shaped structure, and the broad V-shape is then later forms as a narrow V-shaped structure. The arms of the V will get opposed to form a I, and finally the sulcus will be branched to form a Y. Each major sulcus appears at different gestational age, but they follow the similar pattern of evolution. Timeline of sulcation. The callosal and hippocampal sulcus are the earliest sulcus to form. They form at the age of 18 weeks. Pareto-occipital sulcus is seen at the gestational age of 20 weeks, which this is followed by calcarine and cingulate sulcus, which are seen in 24 and 28 weeks. The convexity sulci are seen after 28 weeks. In this, central sulcus will be seen at 28 weeks, precentral and postcentral sulcus will be seen at 30 weeks. Olfactory sulcus will be seen at 30 weeks. This journal by Toy et al.
Hold on. Go back. So where did you get this table?
So from neurosonogram by Ramamurthy. So
the olfactory sulcus will appear a bit earlier than 30 weeks.
Yes, sir.
Okay, around 26, 28 only it will come.
Yes, sir.
Check it out.
Okay, sir.
Rest is okay. Yeah.
The study by Toy et al. This gives the appearance of sulci in their early gestations. So, parieto-occipital sulcus will be seen at earliest at 18.5 weeks, as compared to the mean gestational age of 20 weeks. This calcarine sulcus will be seen at 18 weeks as compared to 24 weeks, and the cingulate and convexity sulci can be seen as early as 23 weeks as compared to the mean gestational age appearance of 28 weeks. So coming on to the individual sulci, the callosal sulcus lines the corpus.
Hold on. In our clinic, we go by Ramurthy sir's table only. Okay.
Yes, sir.
The one that you showed in the previous slide.
Yes, sir.
Will result in a lot of. Oh, go back. Will result in not this next one.
Sir, this one.
Yeah, will result in a bit of an overcall. Okay, if you see in everyday practice, 19 weeks you won't see parieto-occipital.
Yes, sir.
It may be seen in a one-off case, but it has to be 21 weeks for you to consistently see parieto-occipital. Okay.
Yes, sir.
So if you go by this table, then most of the cases you will be calling back for a sulcal assessment, reassessment.
Yes, sir. Coming on to the individual sulci, the callosal sulcus lines the corpus callosum. It runs from the genu to the splenium of the corpus callosum. It separates the cingulate gyrus from the corpus callosum. This callosal sulcus contains a pericallosal artery. This callosal sulcus can be visualized in all the three orthogonal planes like cingulate sulcus. It can be visualized at 18 weeks of gestation. So this is the callosal sulcus seen in sagittal plane. This is a so this is the corpus callosum, and this is the callosal sulcus which is seen in coronal plane, and this is the cingulate sulcus seen in coronal plane. This is the axial plane showing the callosal sulcus and the cingulate sulcus. So cingulate sulcus, this sulcus runs above and parallel to the callosal sulcus and the corpus callosum. It begins below the anterior end of the corpus callosum and runs upwards and forwards nearly parallel to the rostrum, curving in front of the genu, and is continued backwards above the corpus callosum. Both the callosal sulcus and cingulate sulcus are visualized in all the three orthogonal planes. So mean age gestational age at which the cingulate sulcus is seen is 28 weeks. So here in the axial plane, callosal sulcus is visualized. Here this shows the coronal plane visualizing cingulate sulcus, the axial plane showing cingulate sulcus, coronal plane showing cingulate sulcus, and this is the cingulate sulcus in sagittal plane. This is the marginal sulcus. Cingulate sulcus continues postero-superiorly as the marginal sulcus. This is the chronological order of development of cingulate sulcus. So mean gestational age at which cingulate sulcus appears is 28 weeks. So at 24 weeks. At 21 weeks, the borders of the cerebral cortex is smooth. Cingulate sulcus is not yet formed. So this is the 25 weeks where the cingulate sulcus appears as a shallow indentation. At 28 weeks, the indentation has deepened and it forms a broad V-shaped configuration. So at 30 weeks, the broad V-shaped configuration is appearing as a narrow V-shaped configuration. At 35 weeks, the arms of the V is opposed to each other and I-shaped configuration is seen. So parieto-occipital fissure. Parieto-occipital fissure is seen on the medial surface of the brain, and it separates the parietal and the occipital lobes. It is imaged in axial and mid-sagittal sections. So this is the mid-sagittal section showing the parieto-occipital sulcus. This is the calcarine sulcus. So this is axial plane showing the parieto-occipital sulcus. So the axial plane shows the parieto-occipital better than the sagittal plane. In axial plane, parieto-occipital sulcus can be seen near the upper margin of the occipital horns of the lateral ventricles. This is a chronological order for the formation of parieto-occipital sulcus. Parieto-occipital sulcus will be seen at 20 weeks of gestation. So at 19 weeks, the medial surface of the occipital lobes are plain. Here, small indentation is formed at 21 weeks of gestation. The indentation deepens to form a broad V-shaped structure like a sleeping diamond. At 24 weeks, the indentation still deepens and it forms a standing diamond. Here now, here the limbs of the V are opposed to comes in closer to each other to form a narrow V at 28 weeks. At 30 weeks, the arms are opposed to each other to form a I-shaped configuration. This is at 32 weeks where a mature parieto-occipital fissure is seen. Coming on to the lateral sulcus, Sylvian fissure develops as a deep groove separating the temporal lobe from the parietal lobe and the frontal lobes bilaterally. It will be a mean gestational age where lateral sulcus is visualized is at 20 weeks gestation. This operculization is the term specific for Sylvian fissure development. This is the insular cortex. This insular cortex will be initially exposed in the early gestation. As the gestational age advances, this frontal, parietal, and the temporal lobes overgrows the insular cortex and they hide the insular cortex inside. So this frontal, parietal, and temporal lobes grows to overhang the outlying cortex. This bulky overgrowth of the posterior operculum, this process of overgrowth of the lobes to cover the insula is called as operculization. The operculization starts from posterior to anterior end. That is, the posterior operculum, which consists of the temporal and parietal lobes, grows in a faster rate than the anterior operculum. So by 30 to 32 weeks, posterior half of the insula is covered by the temporal operculum. By 36 weeks, the frontotemporal operculum covers most of the insula. The complete closure of the anterior part of the insula occurs postnatally by 2 years of age. This is the insula, this is the lateral sulcus, and this is the cingulate sulcus. Evolution of lateral sulcus. Initially, the lateral sulcus by 22 weeks appears as a shallow pit, and later, at 24 weeks, the margins sharpens and they form a obtuse angle. And later, when the operculum starts growing, the borders become perpendicular. So when they mature, the borders become angulated, acute angles, and at the later stage, they oppose each other to form this eye configuration. Many studies come for the assessment of the Sylvian fissure. The assessment of Sylvian fissure are based on the Sylvian angles or the mode of the grade of operculization and the depth of the Sylvian fissure from the interhemispherical fissure and the height and depth of the Sylvian fissure. So many journals have been published for assessment of Sylvian fissure for early diagnosis of migrating cortical disorders. So this is a chronological. So this following slide shows the chronology in which the lateral sulcus is evolving. This is at 28 weeks where the lateral sulcus is seen as a small indentation. This is at 24 weeks where the angles are obtuse. This is at 25 weeks where the angles are near perpendicular. So this is at 28 weeks where the angles in one side it is acute and another side it is perpendicular because the posterior operculization occurs faster than the anterior operculization. So here it is perpendicular and here it is acute. So at 30 weeks they are almost acute. So 31 weeks the angles are acute. calcarine sulcus. Calcarine sulcus also follows a linear course and it runs from the tip of the occipital lobe to the midpoint of the parieto-occipital sulcus. It is located in the medial surface of the occipital lobe. Calcarine sulcus can be seen on the view visualized in coronal and mid-sagittal planes. In coronal plane, the calcarine sulcus is visualized on the medial surface of the occipital lobe. So in sagittal plane, it is visualized behind the parieto-occipital sulcus. So this is the parieto-occipital sulcus and this is the calcarine sulcus. This is the cingulate sulcus. So at 22, the mean gestational age of appearance of calcarine sulcus is 24 weeks. So here in 22 weeks, calcarine sulcus is not yet formed. The medial surface of the occipital lobe in the coronal section is smooth. So this is at 24 weeks where they are starting to appear as small indentations. This is at 28 weeks where they form the broad-shaped V. This is also at 28 weeks where they're forming a narrow-based V. So this is 32 weeks narrow-based V, and this is 33 weeks where the limbs has been opposed and they are forming a I-shaped.
Hold on. 32. Not this.
Okay, sir. The central, precentral, and the postcentral sulcus. The central sulcus separates the frontal lobe from the parietal lobe, and is the sulcus between the precentral and the postcentral gyrus. Precentral sulcus runs in front and parallel to the central sulcus, and it separates from the precentral gyrus. The postcentral sulcus is a sulcus of the parietal lobe that separates the postcentral gyrus from the remainder of the parietal lobe. So this precentral, postcentral, and central sulcus, they run parallel to each other. So this is the precentral sulcus, this is the postcentral, and the precentral sulcus. This is at 35 weeks of gestation where all the sulcus is formed. This is at 28 weeks of gestation where central sulcus is alone formed. Superior temporal sulcus. So superior temporal sulcus is a groove located in the temporal lobe of the cerebral cortex. This superior temporal lobe runs in between the lateral sulcus and the inferior temporal sulcus. They can be visualized in coronal transcaudate and axial transcerebellar planes. So this is the coronal plane where the lateral sulcus is seen, superior temporal sulcus is seen, and the inferior temporal sulcus is seen. They all run parallel to each other. This is the hippocampal sulcus seen in the medial part of the temporal lobe. So this is the insula, 2 is the insula. This is the lateral sulcus, and this is the superior temporal sulcus. So medial part of the temporal lobe, here is the hippocampal sulcus. Superior frontal sulcus. The superior frontal sulcus runs posterior from the frontal lobe to the precentral sulcus, and it runs parallel to interhemispheric fissure. Here, the superior frontal sulcus is seen running parallel to the interhemispheric fissure in the coronal view. Hippocampal fissure. This is one of the earliest fissure to appear. It is visualized as early as 18 weeks. It is seen in axial transcerebellar, coronal transcaudate, and the transthalamic sections. So here the hippocampal sulcus is seen as a bright light in the medial surface of the temporal lobe. Here is an image. This is a 22 weeks old fetus showing sulcal lag. Here the temporal lobe is not showing any silvery white line. Here the hippocampal sulcus is not yet formed even at the gestational age of 22 weeks. So here the hippocampal sulcus is not yet formed, but the baby is at 22 weeks of gestation. So hippocampal sulcus should be seen at 18 weeks of gestation.
Certainly a target which should be seen.
Yes, sir.
2021.
Yes, sir. The last sulcus, this is the olfactory sulcus. This olfactory sulcus appears initially as a shallow depression on the medial part of the orbital sulcus, and it develops parallel to the longitudinal cerebral fissure. It can be visualized in a coronal plane of the frontal lobes, that is the transfrontal plane. It can be visualized the transfrontal plane at the tip of the frontal horns of the lateral ventricle. It is visualized in a coronal transfrontal plane and the transcaudate sections. It is visualized as early as 26 weeks of gestation. So this is olfactory sulcus seen in the transfrontal plane, this one and this one. So take home message, knowledge of the sulcal development pattern is useful if there is suspicion of brain abnormality as mild ventriculomegaly and in pregnancy with previous problems. The functional integrity and maturation of the fetal brain, psychomotor development, has been assessed based on myelination and sulcal development. However, in fetus, myelination occurs incompletely, starting from the thalamus and brainstem. Therefore, sulcal development is suggested to be more precise indicator of fetal brain maturation in comparison to the myelination. Thank you, sir.
Thank you. Viveka,
Yes,
are you
sir.
going to present or
Yes, sir.
time irka?
Yes, sir.
Sure.
Okay. Kavitha, stop sharing. I'll share myself.
Stop sharing, ma'am.
Is my screen seen?
It is seen, ma'am.
Okay. Good morning, everyone. I'll be continuing on the topic, not quite wired right, approach to malformation of cortical disorders. So the human brain is a unique creation in the universe with immense complexity. How such a complex process is so reproducibly programmed in each and every one of us is truly astounding. And this is mediated by molecular machinery, genes, and complex signaling pathways, which act in a highly coordinated fashion to convert a brain which around 29 days of gestation, which has only small 3 vesicle structures, into a complex structure with a lot of sulci and gyri, as discussed earlier. So this is something synonymous to a orchestra containing many people who have to act synchronously to provide a melodious medley. So what is malformation of cortical development? This comprises of a large heterogeneous group of disorders of disrupted cerebral cortex formation. The clinical manifestations include developmental delay, refractory epilepsy, intellectual disability, autism, and cognitive impairment. So in order to know about the malformation of cortical development, we need to know the cerebral cortex development along with the timelines. So this consists of 3 important phases. The first is neuronal proliferation, which happens between 6 and 16 weeks of gestation. The second phase is the neuronal migration, which starts from 6 weeks to 5 months postnatal life. And the third phase is the neuronal organization, which happens from 20 weeks till adulthood, early adulthood, we can say. So all these phases are overlapping, and this is the timeline of neuronal development, cortical development. So as we all know, by 4 weeks post-conception, the neural tube closure happens. So this is preceded by events like gastrulation, neurulation, formation of a neural plate, then neural fold, followed by neural tube closure. In the meantime, there are 3 vesicle-like structures called the prosencephalon, mesencephalon, and the diencephalon developing. So once the neural tube closes, there is immense potential proliferation potential from the neural precursors. And these neural precursors are placed in the ventricular zone. This is called the ventricular zone. This is called as the factory of neural progenitor cells. The ventricular zone is otherwise called the germinal matrix, or the and also has the median and lateral ganglionic eminences. So this phase of neurogenesis, the neural progenitor cells develops and multiplies in this zone and differentiates from the stem cells into neuroblast and neural glial cells. So once the phase of neurogenesis is complete, then starts the migration. So in this phase, the result of migration is the formation of a hexalaminar cortex. This phase is also responsible for the formation of sulci and gyri. This phase maximizes the cortical volume without increasing the brain volume. So the next phase is the neuronal organization. This is quite a big phase which consists of multiple things happening here, like gliogenesis, myelination, neuronal maturation, synaptogenesis, dendritic maturation, and synaptic pruning. Synaptic pruning is nothing but apoptosis of abnormally formed synaptic junctions, and this continues till adolescence or early adulthood. And all the phases, if we see, are interconnected and interrelated. So the disorders of neuronal migration can be mixed with proliferation, migration, and organization. So a note on the formation of the hexalaminar cortex. So here we have 4 weeks. At 4 weeks, we have the ventricular zone where the progenitor cells are placed. And above the ventricular zone is the preplate, which has the Cajal-Ritzius cells. So these are the primitive neurons. These are the first neurons which lie in the preplate. So as the gestational age advances, there is differentiation of these zones, forming the subventricular zone, intermediate zone, subplate, cortical plate, and the marginal zone. And above all is the pile limiting membrane. So what happens in the ventricular zone is that the germinal cells or the stem cells, which are the neuroblast and the neural glial cells. The glial cells have a potential to form long processes which form a scaffolding from the ventricular zone till the top of the pile limiting membrane. So this scaffolding acts as a guide wire, guiding the neuroblast cells to ascend upwards and settle in the layers of the cortical plate. So this the Cajal-Ritzius cells, which were in the preplate, will be migrated to the marginal zones. These are specialized cells. They have some functions. I'll be telling about it. So once these cells migrate, what happens is they settle into an inside-out fashion. The first batch of neurons will be settled lower down in the cortical plate. So the next set of neurons go above the layer 6, and in the same way, layer 4, 3, 2, and 1 are formed in an inside-out fashion. Thereby, the oldest group of neurons lying inside and the newest group of neurons lying in the topmost structure. So the Cajal-Ritzius cells are cells which reside here. They secrete a specialized protein called reline, a substance called reline, and this instructs the neural cells, neuroblast, to decide where they have to jump off. Like it has to jump off in layer 1, layer 2, and also it acts as a limiting membrane where the neuronal cells do not cross the pile limiting membrane. So when it acts as a coast guard or as a security in a beach resort who prevents from going into the ocean or sea. So when this function is disrupted, over migration happens, neural cells go beyond the pile limiting membrane, forming cobblestone complex disorders. So going about the tangential and radial migration. So this is the ventricular zone. Top is dorsal, down is ventral. So here in the dorsal subventricular zone, radial migration happens. Here are the cells which are which have the excitatory neurons, which is the glutaminergic neurons, and responsible for 80% of the radial migration, which happens directly to the cortex. However, the cells which are residing in the ventral part, the ganglionic eminence, lateral and medial, they are the GABAergic neurons, the inhibitory neurons, which travel in a tangential way, and after reaching there, they go in a radial fashion. This is what is depicted here. Cells go in a tangential way, reach to the subventricular zone, and then take a radial migration. So what happens when the neurons go off the map? So depending upon the phase of affection, there are multiple disorders of neurogenesis, migration, and gliogenesis. For the purpose of convenience and postnatal management, classification of MCD was proposed by James Barkovich. So we can classify it into disorders of proliferation, disorders of migration, and organization. So proliferation disorders include microcephaly, megalencephaly, focal cortical dysplasia. Disorders of migration include heterotopias, lissencephaly, cobblestone malformation, and hemimegalencephaly. So organizational disorders, polymicrogyria and schizencephaly. So this is the nomenclature described for each section. Sir, should I go about the description, sir?
Yes, please. Yes, please.
Yeah. So microcephaly, this is a significant reduction in the head circumference, more than 3 standard deviations as compared to the control groups matched for the age and sex. Megalencephaly, this is significant reduction in head circumference or the brain size, more than 3 standard deviations. So coming to the disorders per se, the first one is periventricular nodular heterotopia. This is basically no migration. No migration happens from the ventricular zone. So the gray matter nodules lie along the ventricles. So this is periventricular nodular heterotopia. The next group is lissencephaly spectrum, which contains agyria and pachygyria. Here what happens is there is impaired migration, which can lead to classical lissencephaly. This there will be abnormal gyral pattern with absent or broad gyri. Pachygyria means broad gyration in combination with abnormally thick cortex. Then comes subcortical band heterotopia. What happens here is partial migration, which can lead to a band of gray matter separated from the cortex and the lateral ventricles by zones of white matter. So this also forms a syndrome called double cortex syndrome because of its appearance. Next is cobblestone malformation. This, as I told earlier, this is irregular pebbled cerebral surface with moderately thick cortex and jagged gray-white matter border with frequent vertical striations. This is due to over-migration. The progenitor cells over-migrate and cross the pile membrane. Polymicrogyria, this is an excessive number of abnormally placed small cerebral gyri with cortical overfolding, irregular pebbled cortical surface, and stippled gray-white matter boundary. Schizencephaly, this is a full thickness cerebral cleft lined with gray matter, which extends from the ventricular surface to the pile surface. It can be unilateral or bilateral, open lip or closed lip. Focal cortical dysplasia, this means cortical dyslamination with or without abnormal cell types. Other features can include gyral and sulcal irregularities, increased cortical thickness, blurring of cortex white matter junction, and white matter abnormalities. These are all MRI findings. And the last one is dysgyria, a cortex of variable thickness and smooth gray-white boundary, but with abnormal gyral pattern characterized by irregularities of the sulcal depth or orientation. So now, malformation of cortical development may be caused due to genetic abnormality, infections, any teratogens, or trauma. A particular MCD may be a combination of any of these disorders. For example, if there is a disorder of migration and organization, which is a combination, the most commonest combination is periventricular heterotopia and polymicrogyria. This is a common combination. And we have a case of that, which I'll be showing later. And the genes that control cortical development may also be involved in the development of other organ systems like eyes, hindbrains, face, and skeletal system. So an example for this is Miller-Dicker syndrome, where there is classical lissencephaly along with dysmorphic faces, congenital heart disease, and polydactyly. So how do we identify or check for cortical malformations? So we directly do not go and search for malformations, but we identify the red flags which prompt us to seek the cortical malformations. So once we identify the red flags, our antenna should be raised and we should seek for the changes. So what are the red flags? Here are the red flags. History-wise, if there is a family history of any neuronal disorder, any global developmental delay, um, or neurological problem, a personal history of the mother or father with this similar problem, or if a previous baby is affected by any neurological disorder. Coming to extracranial anomalies, whenever we find an anomaly of the face, cardiac rhabdomyomas, genetic syndromes, ambiguous genitalia, any skeletal dysplasia, it is good to look for the brain anatomy. Moving to abnormal screening. This is one common thing where our screening views, which will denote some abnormality, prompting us to do a detailed neurosonogram. So that includes mild lateral ventriculomegaly, CSP abnormalities, micro or macrocephaly by biometry, and irregular ventricular wall of the ventricles. And agenesis of agenesis of septum pellucidum and cerebellar abnormalities also prompt us to look for detailed neurosonography. And these are certain risk factors of CNS lesion which can last throughout the gestation, like infections, fetal anemia due to TTTS or TAPS, any drug ingestion or toxins. So there are some new markers for the detection of MCD. However, these are not yet standardized, need more evidence. So first is the cat-ear lines. So cat-ear lines are hyperechogenic lines, hyperechogenic line that can be seen as a continuous line through the subplate and the intermediate zone. So here is the image of the ventricle. Here is the subventricular zone, intermediate zone, and the subplate cortical plate. So it is a continuous line happening in the subplate and the intermediate zone. So this was a paper published by Leona Poon et al. Here, they have described that the cat-ear lines can be consistently seen from 19 to 30 weeks in all cases with normal neurodevelopment. So at 18 weeks, there is something called the pre-cat-ear lines, pre-CEL, which is limited only to the subplate, not the intermediate zone. And the CEL develops around 19 weeks, where it is extending into the intermediate zone. So this picture is seen through 30 weeks. So that is a line diagram, and here is the ultrasonographic representation shown in the picture, where at 16 weeks there is no CEL and there is appearance of pre-CEL in the subplate and extension into the intermediate zone around 18 weeks and lasting throughout. So what happens in what are the abnormal findings in the cat-ear lines? There can be a persistent pre-CEL than the formation of a CEL, only the presence of a CEL present in the subplate. Abnormal CELs can be in the form of mosaic pattern or mass-like patterns happening in the subplate. So this was defined as an abnormal CEL. So according to the paper, the CEL
are you confusing Ritsuko with Leona Poon?
No, sir. This is by Poon, and Poo is also part of this paper, sir.
So it is the work of Ritsuko Po.
Okay,
Ritsuko Po is a
Okay.
Japanese fetal medicine specialist who has dedicated her life in the analysis of the fetal brain in a way nobody else has ever tried or attempted. So the catheter line is one of the original contributions.
Okay, sir.
After that, people join hands and try to make it more useful or expand the research. CEL should be attributed to who?
Oh, sir. Okay. Yes.
Sure.
So the conclusion of the paper was the CEL visualization rate in MCD group was 40%, which is significantly lower than that of the control group. And an abnormal CEL or a persistent pre-CEL should act as a clue or a precursor, like a marker for us to seek for malformation of cortical development. So moving to the next sign, this is Sylvian-Fisher angle. This is again work of Ritsukupu, where here we can measure the Sylvian-Fisher angle. So there are planes, there are description of planes where it has to be taken. It is somewhere in the coronal view of transthalamic plane. As the gestation age increases, the angle changes. So in the earlier gestation, how the angle is measured is there is a horizontal line drawn in the middle, and the angle between this horizontal line and the upper border of the Sylvian fissure is measured. So this is a positive angle at an earlier gestation. As the gestation advances, the upper border of the Sylvian fissure, like as it operculates, it becomes a negative
Tilts
angle,
down. Yeah.
shifts down, and this is the horizontal line, and this angle is measured. So there are normograms for this measurement for the positive and negative measurements. Normograms fall within 10 to 90th centile, and the Sylvian fissure angle, when it falls above the 90th centile, it's a strong indicator of malformation of cortical development, and both the Sylvian fissures should be measured. So now let's move on to the cases. Here first is the disorders of neuronal proliferation. So as we saw, proliferation happens between 6 and 16 weeks. It is the differentiation of stem cells in the periventricular zones into neuroblast and glial cells. So whenever there is neuronal proliferation disorder, whenever it is reduced, it can result in microcephaly. Whenever it is increased or whenever there is a decreased apoptosis, it can result in megalencephaly, and abnormal proliferation can result in focal cortical dysplasia. So we'll see a case of microcephaly. So this patient was referred to us with the history of suspected partial agenesis of corpus callosum and bilateral prominent lateral ventricle. So here is our red flag. History and referral was the red flag. Going to the history of the patient, she is a primigravida with no significant risk factors. The couple were fourth degree consanguinity. And she was on
Another red flag.
Sir? Yes.
Another red flag.
Another red flag, yes, sir. So patient was on thyroxine supplement for hypothyroidism. First trimester screening was not done. So based upon the just LMP, her gestational age was confirmed to be 24 weeks and 5 days. So this is the biometry. I'll come to this. Please note the head circumference is at first centile. So here is the image of the head circumference, which was at first centile. And this is the image of the lateral ventricles. So at 24 weeks, here is the control image where we should have a nicely V-shaped or diamond-shaped parieto-occipital fissure. But however, we are not able to appreciate that in this case. And on measuring the lateral ventricles, there was mild lateral ventriculomegaly, one side measuring 10.8, the other side measuring 9.2 mm. So here is the demonstration of the lateral sulcus. Here is our control image. So at 24 weeks, there should be a proper obtuse angulation on both the sides. However, we can see only one side has this obtuse angle, and this side it is still shallow. It is still shallow here. So we are noting a cortical developmental lag. And also we can see a colpoc. There are parallel lines, there is no visualization of the CSP and colpocephaly configuration of the lateral ventricles. So in the anterior coronal plane, there was a interhemispheric cyst, and on mid-sagittal view, we could see the vermis and pons, but the corpus callosum was not visualized. The vermis and pons were appropriate, measured appropriate for gestational age. And here is the cerebellar view to visualize the calcarine fissure at 24 weeks. At 24 weeks, we should be seeing a slight inundation of the calcarine sulcus. However, here it appears very smooth. There is no development of the calcarine fissure. This is a parasagittal view showing the lateral ventricle. We can see mild lateral ventriculomegaly. However, the borders appear smooth and there are no nodularities. So the extracranial anomalies, when we did a thorough examination, we could see proptosis. This is the facial profile. However, there was no receding forehead. Typical receding forehead was not there. There was some amount of dysmorphic faces. And there was a small muscular VSD and hypospadias. So these are the CNS findings where we found microcephaly, where the HC was at first centile with cortical sulcal lag, colpocephaly configuration of the lateral ventricles, interhemispheric cyst, absent cavum septum pellucidum, which denotes complete agenesis of corpus callosum. So along with the other findings, bilateral orbital proptosis, muscular VSD, and hypospadia, and Likert was subjectively high. We counseled the couple that because of multi-system anomaly, the prognosis is poor, and theirs is a 4th-degree consanguineous marriage. However, there were no similar instances in the extended family tree. We advised them for invasive testing for amniocentesis and fetal blood sampling and DNA storage. Patient did not go for further testing. They had terminated the pregnancy.
Okay, hold on.
Yes, sir.
What we'll do is, because this is an important chapter, we'll wind up here for this part 1. Okay.
Yes.
Kavitha took a little bit extra time, but that was also important. So we will do part 1 and stop here. We'll just address any questions and then we'll come back to this in the next Friday class. Is that okay?
Yes, sir.
Because the cases are very instructive.
Yes.
All the theory discussed all right, but cases needs to be considered and learned from the cases.
Yes, sir.
Right. I suppose you have more than 2 cases, no?
There are 4 cases total, sir. 1 is finished. I have 3 more cases.
Yeah. So we'll do it relaxedly.
Yes, sir.
How to measure Sylvian Fisher angle to predict MCD according to Ritsuki-Pu. So the protocol was discussed in detail in a journal club, and we'll see if the recording is available. But take a 3D in the A plane, the coronal view should be shown. In B plane, show the sagittal view, the corpus callosum horizontal, and in C plane, the ventricle should be shown such that the frontal ventricle faces down. Okay. When you get like this is right side and this is left side. So the side is important in Ritsuki-Pu. Then when you see the CC horizontal, there is that tila choroidea of the 3rd ventricle also will be seen and put the dot in the anterior most. That is the control where the coronal is going to happen. And at that, in the A panel, you can measure. The horizontal line is already given by the orthogonal lines of the 3D plane. Then you can measure the angle right and left. All right. Guha. Oh, sorry, this is Preeta. In case of HC more than 3 standard deviation, 26 weeks extended NSG, is it sufficient to see Pareto occipital circus or Paglos? What do we need? Anytime when you do a neurosonography, part of the assessment is the cortical development. So you need to assess the ventricular system, you need to assess the midline structures, you need to assess the hindbrain structures, you need to assess the cortical development. Cortical development, volume, symmetry, of course, lamination, cortical folding or maturation. So you need to, and as a screening, okay, you can say that only the lateral sulcus, Pareto occipital, because they don't come under your usual planes. But when you are doing a NSG, you should do all sulcus appropriate for that gestation. All right, so I hope you will have a lot of queries, but keep it. We will continue in the next class. Next Friday, we will meet and continue this NSG thing, the cortical thing. Yeah.
Thank you, sir.
Okay. Monday presentation is there, no?
Yes, sir.
Okay.